wonderful presentation, and I can, if you want, you can go sit there, and we will move with the next session. So we are now going to the presentation of the outcomes of each key thematic area. We will start with Lombardy and Fondazione Regionale per la Ricerca Biomedica, who are in charge of the big data, electronic health records, and health governance area. Paola? There is there's a message from the regional authority, and then you can come. Sorry. I would invite on the stage actually Paola, Marcin, Donata, and Eva. If you want to join the stage. So for each presentation, we will have an institutional welcome from the regional authority, and then we will go in depth into the presentation until the coffee break. Video.
Good morning to you all, and good morning to the coordinator and the partners of the project Region4PerMed. I'm Alessandro Morosi, Director of the Research and Clinical Care Networks at Lombardy region. I'm honored to take part in this meeting on behalf of the region and introducing FAIR-RRB, the Regional Foundation for Biomedical Research, one of the main strategic platforms for boosting progress, research, development, and innovation within the health sectors among the regional academic and clinical stakeholders. We are extremely happy to be part of the Region4PerMed consortium, as we strongly believe in the goals of this project and in the need of coordinating and aligning regions through a permanent dialogue on the actions to undertake to promote personalized health. I'm even more pleased that we are having this meeting here in Brussels, in the heart of Europe, for a day where not only the achievement of the project will be presented, but also the main challenging issues for the European Union will be discussed. Access to healthcare, aging population, healthcare technology and big data, ethical issues, and all this after the experience of a global pandemic. All these aspects cannot but be tackled through the strategic approach of personalized medicine. Personalized medicine has always been a priority for Lombardy region, but over the last few years, and especially after the terrible experience of being the first region in Europe to be severely affected by COVID-19, Lombardy region has been moving forward, introducing important reforms in its regional healthcare system. Building on the 2015 reform, where the concept of care was expanded to become taking care, and where for the first time personalized treatment plans and personalized assistance plans were introduced, the reforms aimed to shape different organization of healthcare services, bringing them closer to the population through the establishment of community houses and local clinics to provide first care services and community hospitals for more serious cases. The reform emphasized the continuity of care and assistance, in particular for those affected by chronic diseases, and this can be read within the framework of personalized medicine, more patient-centered. The reform highlights also how innovative solutions are needed to provide better services, including an extended use of telemedicine, increasing the autonomy and independence of patients and caregivers. Lombardy's strategy is also committed to invest in research and innovative projects, in line with the national strategy. As some of you may know, Italy is implementing a national recovery and resilience plan, which outlines the strategic directions, the aims, the reforms, and the investments that Italy intends to implement thanks to the use of the European funds from Next Generation EU, a plan of national investments in a number of sectors, including healthcare. In the health sector, the plan foresees important investments in infrastructures, particularly within the purpose of making local community care more widespread throughout the territory to guarantee primary and intermediate care, especially for the most fragile categories. Obviously, data, big data, and technology are essential tools, as well as investments in technological and digital innovation to promote a better management of data and dissemination of the electronic health records. Health, along with life science, is considered among the ecosystems of innovation included in the Smart Specialization Strategy 2021-2027 approved by Lombardy region. Here, it is interesting to notice that personalized medicine is incorporated into the concept of 5P medicine: participatory, personalized, preventive, predictive, psychocognitive. And even within a strategy dedicated to innovation, the preferred approach is patient-centric. Data, big data, and their interoperability are essential tools for personalized medicine. Technology took an enormous step forward, but technology alone does not solve problems. We need new experimental designs, appropriate controls, collaboration between different professional figures, a new governance system. We welcome all advances promoted by the European Union, such as the European Strategy for Data, aimed to creating a single market for data that will ensure Europe's global competitiveness, the European Data Governance Act, the proposal for Interoperable Europe Act, the creation of the European Health and Digital Executive Agency, ADEA, as well as the 1+ Million Genomes Initiative, the EU initiative on genetic data sharing for research. Current challenges and opportunities can be faced only through a strong collaboration, joint efforts, and commitments of us all. And now, I'm glad to give the floor to Paola Bello from the Regional Foundation for Biomedical Research, that will explain the work realized so far by FRRB in the area of big data, electronic health records, and health governance. Thank you. Looking forward to all presentations and discussions.
So, Paola, you have been presented by... so go ahead and give us...
Per muovere le slide?
Qua avanti e qua dietro. Qua c'è.
Qua avanti e okay. Good afternoon, everyone. I am Paola Bello from the Regional Foundation for Biomedical Research in Lombardy. First of all, thank you all to be here, and a special thanks to the coordinators and all partners. So I'm here today to present the work that we realized as partner of Regions4PerMed in the area of big data, electronic health records, and health governance. So let me start by something that normally is done at the end of a presentation, which is keywords. However, we think that these keywords really represent what emerged from the discussions and from the workshop and the conferences that we organized specifically on this topic. So first of all, technology. We live in a more and more technological world, and in which way technology expresses itself in healthcare? Well, for instance, through big data. What is big data? So in theory, big data are considered a huge amount of data that are so complex, so high in variety, and that increase so fast that it's difficult to manage with the current systems. So we need new system to use this data, to use this amount of information that is increasing. And what do we do with big data? Well, if we want to make a good use of them, we need to share them. We share them with the research world, with the healthcare world, obviously, but with the patients as first. I mentioned research. At the moment, healthcare finding proper treatment cannot be done without the support of research. And in particular, the more we study, the more we collect data, the better treatment we can offer. And this is nothing but the definition of personalized medicine. Again, now we live in a place where we have more and more information, more and more data, and data can create evidence. But thanks to this, we need the influence, we need the decision of our policymakers who are in charge of the decision-making processes. So data can be a useful support for decision-making, but also policy-making is what we need to make sure that we have a strategy to take decision. Ethics. We are now faced with ethical challenges that were not there before. Who owns the data? How do we manage data? What do we do with data? What is the value of data? And obviously the last keywords possibly is the most important, patients. all the work that we are doing on big data, on personalized medicine, is for patients. So while dealing with this area, with the collaboration of the coordinator and the other partners, we organized 2 major events. The first was a conference held in 2019. After that, you see the program was very dense. We also organized a couple of in-situ visits. In particular, with the partners of the consortium, we visited the organization area, which is in charge of all the IT system in Lombardy, and also a cryobank, a biobank, at one of the major hospitals in Milan. So I'm not going to focus on the main and the single aspects of the conference. I'm going to focus on the lessons learned. So we invited for this conference a number of experts, a number of stakeholders coming from the academic world, the political world, the European Commission. And what we discussed was that the amount of data that we now have, and that is increasing, can drive research and enable healthcare transformation, but data alone cannot do it. We need a regulatory system, we need guidelines, we need harmonization and standardizations. We need the involvement of different policymakers, and we need the involvement of different stakeholders, from patients to healthcare staff, to regulators, to regions, as normally regions are the kind of government that has the biggest proximity with citizens. Massive amounts of data could change how clinical decisions are taken. As we said before, clinical decisions can be based on the evidence provided by data. However, data will not replace clinicians. Clinicians will always be there. However, it won't be just a matter of clinicians, since the competencies that are now required to deal with technology, to deal with information, are not the same as before. New training programs should be created, and also new professional figures should be created to accompany, to be together with the healthcare staff in our hospitals. To foster the transitions towards a data-driven health and care, we need a governance system, an adaptive governance system, and a system where regions can play a major role. After that, a few months later, we organized a workshop, and the idea was to extend the conversation to a variety of stakeholders, coming also from different sectors, including the private sectors. So the idea was to have the discussion divided in 4, let's say, parallel sessions, each of them dedicated to a particular topic. So the first one was about data integration and interoperability. The second one, investments on big data infrastructures. Third one, healthcare organization in changing environment. And the fourth one, promoting access to data. Once again, I'm going to present you the main, and that was obviously the second day where we focused part of the meeting to the capacity building and some best practices coming, for example, by the so-called regions, the 4 motors of Europe. So I'm going to present here the main outcomes of the different sessions. As I said, the first one was about the integration and interoperability of data. So now we talk about one of the major challenges that we have right now. There is an increasing amount of data, but what do we do with that? How we collect data, how we share them. It's fundamental that we as hospitals, as researchers, as regions, and then national government, and even higher above, we need to find a way to standardize the way we collect data, that we integrate them, and in this way, we can make them interoperable. Obviously, this requires a collaboration of all actors involved, and not only from the IT sector, but we need multiple disciplines. We need different kind of professionals involved. In countries where regions, like our countries, where regions are so key in the implementation of the healthcare strategy, regional healthcare governments can really play a fundamental game in supporting this kind of collaboration and in creating a governance framework for this to happen. Another point that is extremely relevant in this overall new management of data is the citizens' trust. Obviously, citizens are more likely to provide their data and to be able to share them if they have trust in their governments and what the governments or the representative can do with their data. The second session was dedicated on investments in infrastructures, and that is the sessions where we focused on the collaboration of the private and the public sectors. It's undeniable that the importance of the private sectors and of the private companies is fundamental. It gives a boost to technological research. And public and private sectors are asked to work together, to collaborate together. We see already some forms of public-private partnership working very well. We see some smart specialization strategy integrating a variety of stakeholders in their implementations. And we see a number of factors that are really starting to understand the power of a joint collaboration. Policymakers are asked, again, to talk with different stakeholders that can have different interests from them, but can work on a common framework for a common benefit. Third session, it was about healthcare system in a changing environment. Well, first outcome, healthcare systems are under stress. That's definitely not a surprise. But what is, in a sense, surprisingly sad is that the conference was held in 2019. So that was the situation already before the pandemics. And we can imagine, and we know what is the situation right now. In particular, over the last few months, we assisted a growing number of strikes that involve healthcare staff. Obviously, our hospitals, our healthcare system cannot go on working in the same way as before. True, we have new opportunities, we have new instruments, we have new data, new technology. And for this reason, we have new opportunities, we have new challenges as well. And we cannot try to face them with the same instruments as before. So not only we need more resources and more staff, we need a new organizational systems. As said before, we need new professional figures, we need new technologies, we need people who are able to be, in a sense, the liaison between technologies, clinicians, and patients and their families. Who is in charge of the change of the organizational system, of the governance system? Well, again, there is a plurality of actors, but in our case, regions can be key actors. How they can do that? Well, for instance, supporting changing across policy levels, encouraging the adoption of adaptive management. Again, we need to understand that our territory are different and they have different needs. So as you may have heard before from the representative of Lombardy region, now with the new reform, we are trying to take a step forward by taking a step back. So we understood the importance of the proximity healthcare, to have a local GP, someone who can collect the needs of the citizens. And maybe they can do their work in a better way with the support of technology, but still it's a whole new system that has to be managed. So new form of trainings should be provided, and obviously new investments in infrastructures and their implementation. Finally, the outcomes of session 4, that was about the access to data. So we mentioned at the beginning the importance of sharing data. Who needs to access those data? Well, definitely researchers. We need data to progress in our research. Investors, including pharmaceutical companies, to create new drugs, to advance in technologies. And obviously patients. In the end, it's their data, our data maybe in the future. We need to understand, while dealing with data and the possibility to access them, their intrinsic value. So all actors can consider data of a different value, but data have always a value. May they be big data or even small data. The access to data should be regulated, as we said before, should be ethical, and most of all, should be equal. again, we know that not in all regions, not in all our territories, digital health is common for all. However, it should be our efforts and the efforts of our region to provide access to the most efficient digital health to all. Otherwise, we are just going to create a different kind of inequality. Ethics issue obviously should be addressed. Data property, data value, responsibility for data management. And we are reaching the end of the work on this area. So we try to elaborate, collecting all the information gathered in these meetings. What could be the key messages to European regions? Well, first of all, we call ourselves and all the other regions to acknowledge the fact that they have a deeper knowledge of their territory, and this comes with a responsibility. Because they have a deeper knowledge of their territory, they are likely to be perceived more effective and hence more trustworthy. But we know that trust is delicate because citizens expect answers to their need. Complex issues such as managing big data and technologies and the constant challenges of healthcare require a constant dialogue among all the actors involved. And regional coordination could be key in involving all the stakeholders, both local and national and European stakeholders. Finally, regions have a strong interest in developing new data-driven technology. They can drive investments. They can call stakeholders to invest in their own territory. And through the investments, we can really see the regions becoming the creators of a proper data ecosystem. Last information. Well, I know that tomorrow we will have the award for the best practice, but even in the area of big data, electronic health records, and health data governance, we had a collection of best practices. We collected them in a booklet. I believe that the report that we drafted can be downloaded from the website, so I invite you all to read. And by this, I thank you, and I'm open for questions. Thank you.
Okay. Is there any questions from the audience? I just wanted to add that when we had this, I'm very happy to witness that many of the ideas and outcomes that we received in the 2018 and 19 with the kickoff conference and the thematic area on big data have been let's say now tackled by the European health data space. So I'm not saying that we we promoted it. I was just saying that we were on the right page, like that all the outcomes that were discussed and the challenges discussed are now being tackled at the regulatory level. And I hope that many of those challenges will be sorted out with the new regulation. I remember during the kickoff we had a talk by Peter Capiten, who is the coordinator of one big patient organization, and the name of the talk, which opened the conference, was Data Save Lives. And I really hope that with the Regions4PerMed and the discussions that have been enabled, we will be eventually able to use the data to improve diagnostics, therapies, and prevention for patients and citizens. There are two questions. Olga first, and then Charlotte.
Thank you very much for your very interesting talk. I think that you touched a very important issue, namely the cooperation with patients. So what is exactly your strategy to involve patients and to increase their trust in what healthcare is doing? Any solution?
So the relevance of patients and patients' organizations is increasing, and also I would say it's more and more recognized by all the partnerships that now are taking place in the field of healthcare, and we also have a big request by the European Commission to involve them. What has been the problem so far? for many funding agencies, ours includes, patients' organizations obviously have always been very important to consult, but they were not considered as part of the research, because the idea is that research is preclinical, clinical research is not providing a contribution based on their experience. Well, thankfully, this idea is changing, because again, we cannot talk about personalized medicine if we are missing the impact that any kind of treatment, any kind of cure has on patients. So the idea is to involve them more and more in different ways. So for instance, developing a research project, so starting from their actual needs to say, okay, what we can do to improve your life, what we can do to improve the life of your loved ones. For many of us working on ERANET, so preparing the calls for proposals, the idea is to involve patients, asking them, okay, how shall we structure this call for proposal? How can we structure it so that it's clearer that we want an impact on patients? Patients are now more and more involved in the evaluation of project proposals. So obviously not all patients' organization can be focused on the scientific part, but maybe on the implementation part, the impact that it will have, the communication part. So I think the way to involve more and more patients is, first of all, a cultural change, taking care of including the opinion of patients is part of the research. And the second one is ensuring appropriate funding for them and for their participation.
If I may add, because we have specifically addressed the public trust topic within the socioeconomic key thematic area, and I don't want to spoil the presentation, but one of the points that also emerged in that conversation is the complete lack of patients and patient representative in the ethic boards. When you submit your clinical protocol, you have a lot of regulatory experts, clinicians, but there is no, which are always adopting this paternalistic approach, so deciding on patients without having ever consulting the patients. So one of the things that was advised is to actually include patient representatives or patients who have a kind of training to join these ethic boards, so they can actually be in part and bring directly the voice, and also build a public trust mechanism based on transparency, frank communication between clinicians and the patients, and also the use of language is very important, because we need to use a language that is capable to communicate the right things to patients and citizens, because without their trust, and we were discussing before with the a regional agency, where people working for the electronic health records systems do not accept to give access to the healthcare systems, which is clearly a lack of trust, while on the other side they're taking selfies and accepting all the cookies and so on and so forth. So there is a public trust to be built, I would say, almost from the outset. Jean-Luc?
Just, yes, I think it's important to talk about patients, but also maybe citizens to enlarge, because we are patient at a moment of our lives, and but we are generating data all the time. And there are two elements that I think are very important, and I didn't capture exactly where the regions are in this respect. The first is cybersecurity. We know that hospitals are weak target for hackers, and there have been a lot of blackmailing of hospitals, and this can be solved, but indeed it means a lot of investments, and I don't know if the regions have really thought about budgeting these investments. The second point is the issue of anonymization of data for secondary use. Having the data managed at the level of a region is nice, in the sense that there is a proximity, but the smaller the geographical area you have, the highest level is the probability of identifying people behind this, because you just have to cross a few data to finally at the end know who is behind. And with artificial intelligence, it's even more easier. So Is there something a little bit advanced at the level of regions regarding these aspects?
So thank you for the questions. I think they're very much connected, and actually in a sense they're both related to the topic of governance. So in many countries, again, like ours, regions are in charge of providing healthcare services, which means not only to organize hospitals, but also to build informatic structure that contains patients' data, that can ensure the provision of prescriptions and so on. The fact that they are subject of cyber attacks, yes, that's a current problem, and it's happening, I think, at least everywhere in Europe and even above. So obviously we need protocols and we need strategies. Can regions alone do something about it? Maybe in the short term, but obviously not in the long term. And the same goes for the need of managing data and make data possibly integrated with other regional data or other national data. We need different level of governance, but all these levels should talk, and there must be an overarching framework. Otherwise, it will not work. So I perfectly agree. One region can have a perfect system of managing data, of providing information to patients, and maybe a high level of security, but then the region next to it doesn't have it or has a different kind of language for collecting big data. So considering that health is still a national competence, then I believe that member states, as national governments, should really provide a framework, both for security, for data collection, for data management, but this framework should be decided at a higher level, even more, with all the other member states of Europe, because we know that data travel, they move, but people as well. So it really makes no sense to talk about global health and then local health and local data. So I would say there's not obviously an easy solution, but the idea is to have local management, but higher governance, national governance and overnational governance.
And if I may add, and then I'll give the word to Monica. So to your first question, and as Paolo was suggesting, usually, especially in the countries where healthcare is organized locally, there are the so-called health data agencies, which are in charge of building the IT environment around the healthcare organization, so collection of data, and also taking care of cybersecurity aspects. We went in ARIA, which is the agency which does this for Lombardy, and they are in charge of this kind of information, so it's up to them to make sure that cybersecurity standards are met. And for the risk of de-identification, there are multiple papers now that are showing that it's possible. I mean, in practice, it's very likely that with the genomic information and few more information, there is a risk. It is possible to re-identify people. And one of the things, and again, I don't want to spoil the fifth thematic area, but one of the easiest thing is to address this within the patient consent form, to communicate about this risk to the patient. So in this case, you can still build trust, because if they get re-identified, you are not saying everything is anonymous, you will never be re-identified. It is possible. Technologically, it is possible, so it is okay to address this within the patient consent form in a way that even if this happens, the research can still go on, and at the same time, you will not losing any trust from the patient. I don't know, you don't look satisfied.
Okay.
Okay. Oh, but I'm very, very happy.
I see the two ladies on your right and on your left.
Okay. So I'm happy to.
No, if I can just
Oh, yeah, sorry.
That's all right. So I don't know if technologically it's possible to make data completely anonymous, and if so, up to which level. I think, again, it's a matter of ethical compromise. So at some point, if you provide access, of course you should, in a sense, guarantee the maximum anonymity as possible. But if some more information are needed, and let's say in the best case scenario to provide and to create better treatment, then there will be always something more. Maybe it's up to us and to our policymaker to decide how acceptable it is to this compromise. Was there an additional
There was
question?
Monica.
Okay, the technique is working, right? Okay, that's really great, by the way. So congratulations for already the great talks. I had 3 points, and I think the first one was already tackled also by Jean-Luc. It was a question, and I didn't know where to put it in your 5 aspects. So it was a question on communication. What we learned a lot is that communication really happens and arrives at the local level. And I see that for the patients, I think it's in the 5th part, while the question is really on the citizen, especially when we think about prevention. But I'm not sure if that was the initial starting point also from the project. But I think here really the regions might play a really, really important role for the question of communication, also towards the citizens. So that was my first point, but that was already more or less mentioned. The second one, I'm not sure if you mentioned it, I'm just interested. Because we're talking about data, it's a lot harmonization, it was a lot technical aspects, but the problem is already collection of data and having the same quality and harmonization of the data being collected. And I think this is also differs from one center to the other, maybe even from one floor to the other in one hospital. I'm not sure. So how was this tackled? Maybe you mentioned it and I missed it. And my third point, I think I just lost. I will come back maybe. Thank you.
Can I? So starting from the last point, so let's say it would have been maybe a little bit too ambitious to find a solution to the diversity of data collection across hospitals and regions. But what we try to do with the project, and in particular with this area, is to raise the attention of the policymakers. They cannot consider a success their data policy strategy if it's only local and if it's very limited to their territory. So what we are trying to address is the challenge not only to make a data collection, a health data collection, accessible and efficient, but the data set needs to communicate with other data set. Because otherwise, especially for chronic patients, maybe they, even within the same region, they go to the main hospital for treatment, but then they will go to local hospital, for recurrent prescriptions. And sometimes the communication is not that smooth. So raising the point, drawing the attentions to the interoperability of data is what we tried to do and that we keep on trying. And I would say after the last 3 years with the pandemics, the importance of having communicable data and the way also to present data should be not about the same. This is something that we saw at the very beginning of the pandemics. The way data were presented in Italy and in other countries was so different, right? Even though in the end the pandemics was the same for all. So, and in this way I connect to your second question that definitely was dealt in the other key strategic area, communication. Communication is key, and it's difficult because, again, we are assisting a different cultural change. So it's no longer the medical staff informing the patients of what's happening, but maybe are the patients asking the clinical doctor what's happening. I'm sure that many of us, me included, sometimes have the big issue of consulting Dr. Google sometimes, which is very wrong, but in a sense, there's a need of information, of trustworthy source of information. So the way information is provided is becoming also key, but I'm not sure that, except a few exceptions, we are really ready in our healthcare systems to have these professional figures dedicated to create a proper communication to patients. Sometimes communication is left to the nurses or to the clinical doctors that are in charge of the patients. But I'm not sure. Is there a common healthcare communication system in place? Is there a healthcare communication policy in place? This is something I think we should work on.
And I totally agree. And just to further elaborate, I think when one of the discussion we were having, and I think this was Professor Bellazzi who joined the conference, one of the things that emerged is that there are already standards to ensure data quality when collecting, and also ensuring that the process for data collection and data validation is sound. There are some standards that have been, let's say, accepted by the international community, and those standards should somehow be communicated and promoted and a different level, like regions, hospital-based. That would be already a great step. Then there are other problems down the road, but this would be already a great start for ensuring data quality. Okay, thanks a lot, Paola. Thanks a lot for the interactions. So we are now moving to the second key thematic area. The second key thematic area is on the shoulders of our Polish partners. I think we are going to start with the institutional welcome from Marcin Krzyżanowski, I hope I have pronounced it correctly, from the Lower Silesia Marshal Office, and then we will dig in the key thematic area 2.
Okay. Good afternoon, ladies and gentlemen. So I am very glad and happy that I am here with my colleagues from Lower Silesia region. So we are very glad to be part of the project which initiated dialogue, exchange of experience and stakeholder engagement in personal medicine and personal health. After COVID-19 pandemic, we were finally able to organize in-person visit in Wrocław at the 2nd and 3rd February this year. So we had the pleasure of hosting project partners. The meeting gave us an opportunity for detailed presentation of Lower Silesian personalization in the area of transfer of scientific and research solution to healthcare system. The meeting showed how and confirmed that tools and mechanisms for creating and introducing innovative concepts in the field of personalized medicine are being developed within the Lower Silesian ecosystem using technical resources and support for the business environment, enterprises, but also using the scientific potential, know-how and creativity of entrepreneurs. Regions4PerMed project has enabled the identification of actors involved in personal medicine in Lower Silesia, observing the development of the implemented technologies during project's implementation, identifying challenges, the implementation of solutions in the field of personalized medicine, outlining the challenges faced by personalized medicine. And at the end, I want to give you some other perspective. So what does it mean for me, the personalized medicine? For me, is the personalized medicine show the spirit of the free nation, the spirit of free Europe, because I mean the place of human being, humans' health, because so it shows us the importance of human beings and human lives. And every life is important. For every life we should fight for. And so we are living in a very difficult time. So we are talking a lot about the pandemic. So now we have a war in Ukraine. So a lot of economic problems. And so the question is, what is the answer? And I think so more cooperation, more common projects. This is the answer. I think it's the only answer, and therefore I hope that this project will continue, and we are strongly support this. Thank you very much.
Thank you very much, Marcin. So now we will start with the KA2 the main results. I think Professor Donata Kurpas from Wrocław University will introduce the topic.
Thank you so much. And we were really lucky to join this project and this wonderful consortium thanks to Lower Silesian Marshal Office. So thank you once again. It's extremely important project for us. We are mainly physicians and professionals connected with medicine field, and the importance of cooperation with local communities and with citizens, not only patients, is increasing. So let's start with introduction from our rector, Professor Piotr Ponikowski.
I am really thrilled that Wrocław Medical University participates in this project, Regions4PerMed. Personalized medicine, which is the main objective of this project, the objective which is the future of the medicine, I have no doubt, will be spread across Europe. 5 different regions across Europe, and Wrocław Medical University, which will deliver the scientific content as the only academic partner. We are privileged, we are happy that we belong to this consortium. We have received a lot of credit, and I am sure that together with the other partners across United Europe, supported by the European Commissions, we will deliver.
Thank you. And what was the main purpose for this part of our project? How to improve data for better and more personalized health technologies? How to tackle regulatory aspects of personalized health technologies? And the main and the most important, patient engagement in meaning of empowerment. How to engage citizens and patients with tools to better manage their health, and again, in meaning of well-being, not only somatic health. Training programs for healthcare professionals and everybody connected with healthcare and with social care, like caregivers, and health technology assessment for health innovations. So we organize conference and workshop, and as you can see, almost 90 participants registered for conference. We had 19 speakers, we have 4 chairs, we have 17 countries included, and the average time in Rome was over 170 minutes, which is extremely high when you consider online event. So the same about the workshop. 2 days, 77 participants, 6 chairs, and 14 speakers. On these 2 slides, you can see our experts from conference, and on the second one from workshop. And main topics from the conference. 4 sessions, opening session which focus on health technologies from the perspective of region. First session connecting the regulatory aspects with personalized health technologies. Then patient engagement, how to engage citizens and patients with tools to better manage their health, and healthcare and AGA for health innovations. And about workshops, regulatory aspects, connecting and data integration, health innovations for healthcare, innovative personal data management, remote monitoring and teleassistance, and access to personalized data. Already difficulties connected with connection data in different settings and personal data of patients were mentioned during our discussion. So, which are outcomes? And you should know that during this part of the project was born as well our project baby, which is the PhD of Dorota. So Dorota will continue this presentation with the main outcomes for her several publications. It's a really hot topic now because we received a couple of days ago information that one of her publication, and it was like 2 weeks ago, was already cited by 3 authors and viewed by over 2,000 of researchers. So, main outcomes for conferences. Personalized medicine really requires cross-border and interdisciplinary collaboration. So, not only local governments, not only local communities, but as well other stakeholders. And always, let's include patients and citizens. And I think that really medical societies are a good example because let's focus, for example, on Cardiology European Association. There's no guideline just now, was not involve patient in preparation of this clinical guidelines for really physicians. The second main topic is developing and validating the potential in providing proven tools, solutions for patients and healthcare providers. Patients in meaning of WHO definition, so it's not only a really sick person, it's everybody who has any connection with healthcare. So it could be completely healthy person. New methods to gather the patient's voice should be used to validate new organizational healthcare settings, like we have really in the USA. Maybe it's not a better example for health outcomes, but for organizational healthcare, it could be really a good example because they assess really 2 items, economical effectiveness and patient satisfaction in meaning of experience when you're really using healthcare services in the certain institution. Then prevention, which was our past, which is our today, and which will be our prevention if we would like to achieve sustainable healthcare system. And workshop. I'm trying to go forward. Forward? Yeah. Oh, thank you.
Maybe it's pointed. I don't know.
A workshop.
Okay.
It's fine?
Yeah.
Yeah? So it's the best example for good cooperation,
Yeah, exactly.
which is the need. And implementation integrated care should be included in each approach when we think not only about healthcare but as well social care. And we are speaking more and more about joint efforts of health and social care. And we know dividing one section from another just doesn't work for patients. Maybe it works for regulations, but not for the well-being outcomes. Ensuring quality and long-term sustainability thanks to personalized medicine. Policy should be based on planning and a structured approach with inclusiveness of patients, citizens, and prioritizing health services with approach and with the focus on needs of patients. Because really the healthcare is not organized for healthcare professionals and all professionals connected with healthcare. Healthcare is organized for patients, for caregivers of these patients. Collection of personalized information, how to really do this, it should be included. It was discussed in detail during workshop, and broader and more systematic implementation of ICT in the healthcare section. So final recommendations are that harmonized strategies to update the curricula of future healthcare workers is the need. Standards, processes, platforms to facilitate broad use of digital tools, big data, advanced analytics across our neuroscience portfolio should be encouraged. And technology can help in detecting emergencies and supporting healthcare professionals by giving them early access to health information and recommendations. The earlier, the better for the final outcome. And public-private partnership should be encouraged in this field, and you see this already in new calls of the European Commission. The institution of multidisciplinary teams is fundamental, and artificial intelligence is becoming part of our daily life. For sure, you have already experience based on chat AI.
Want me to cooperate a bit more? There.
Oh, so Dorota, floor is yours.
Thank you very much. And as was said at the beginning of our presentation, that the Wrocław Medical University was the academical partner of the consortium, and in this context we decided to open a dissertation, which will be the one of the results of the project. And the methodology of our research was, the first of all, desk research, and then qualitative research was conducted among the stakeholders of the Regions4PerMed projects and among the members of advisory board, lecturers of the conference and workshops, and participants of these events. We've got the online questionnaires and also focus group interviews.
I don't know what's going on. I can.
Okay, thank you very much. And, what was the aim of the studies? Of course, we want to investigate and identifying the intervention that would remove the barriers to the implementation of innovative intervention and identify the best practice implemented in the European countries which support the implementation of innovative intervention of the field of personalized medicine. As I said, the three types of research were conducted: systematic review, semi-structured online questionnaires, and focus group. Thank you. And semi-structured online questionnaires included demographic questions regarding age, genders, and nationality, which allowed us to better understand the backgrounds of the responders. And then we include two questions related to individual experience, so with the barriers and facilitators, and 5 questions about the implementation of the personal medicine. The whole data were collected from the 85 responders. Interviews came from 20 countries. It was like Ukraine, Italy, Germany, Spain, Poland, Denmark, Belgium, Great Britain, Latvia, Canada, Estonia, Turkey, Romania, and so on and so on. So it was a lot of data. And the age of respondents was ranged between 24 and 74 years. And then we conduct the focus groups. There were 3 categories of participants in these online focus groups: the observer, moderator, and the respondents. We've got 3 focus groups. So they were just took place on Zoom platform, and we've got the questions about individual understanding of personal medicine, key facilitators and barriers to public use of personal medicine, and about the relation to respondents' private opinion about the ease of adapting personal medicine to citizens' needs. Okay. And I will show you only the most important points that we can see in my results. For the rest of the results, I will just, I hope that you will just use all our research and you will just check it. And first of all, noticeable are the difference of the personal medicine definition, and it was the most yes, it was the most important important thing, because the responders' definition was the difference of the definition was evident because the one part of the respondents decided the personal medicine is only individualized medicine based on genetic testing and the health interventions. For another part of the respondents, the personal medicine was the same as was published in the Council conclusion in December 2015. But for another part of the responders, personal medicine exists always, where are the moments when care takes into account personal risk factors. So there was a lot of difference of the personal medicine. Then what was highlighted in all our research, the data protection. The problem of the data protection, because all the researchers just show that there are big problems and big ethical issue because there's a risk of leaking genetic data and medical data. And also the data collected has a different format, and there's a problem with collecting them in one database. But what it was mentioned, that the also is a positive feedback, because of the there is a possibility to shape the entire health policy in terms of their health needs. So next, what was pointed, that it is important to have changes in the systems in the government level. And for better dissemination of knowledge about the personal medicine, a system change is very important, and it is needed if the personalized medicine will be implemented on the large scale. That is required a lot of efforts on many levels. The biggest mistake is to expect far-reaching short-term success. And also it's really important to show the decision makers the way, and it's essential that we will have the good examples from other countries. And also the next result from our research is the trigger of the change, the citizens. The citizens are the trigger for the change. It needs to be explained to them what they would gain from the personal medicine, and they should be engaged and involved in the decision-making process. And the biggest barrier, what was highlighted in our research, are finances. Public personal medicines requires massive investments, and hard decisions have to be made about the affordability of personalized medicine and the cost implication of other service. Also, what was highlighted, the education. It's crucial to educate and discuss the concept of personal health and personal medicine. And I think that what I want to say at the end, the dissemination. We just forgot about the dissemination, and this importance of better dissemination knowledge about personal medicine, sharing the information in the media, in media society, and increasing the quality of advertisement and the meetings with all the stakeholders, including patients. And I hope that my scientific research will help just to show to you what are needed in personal medicine. So thank you very much.
Thank you. Thank you very much. I have a question. I mean, a couple of questions. But the one, Donata, you mentioned is the dissemination within medical societies. Mm-hmm. And this is something that we are also trying to understand, because if there is something we haven't actually tackled in the frame of Regions4PerMed is the medical the role of medical societies as a key stakeholders. Mm-hmm. So I would like to hear your opinion on this. I mean, how can we engage with them, and which is, according to your experience and also to your research, how can we do that? And if it's if it has an impact to that's it.
So I have good news and bad news. Good news is that
usually we start with the bad news.
Okay.
Just kidding.
You already started the process. Inviting the university for such project is a good beginning. Okay. But then you need a key person in each of these associations. Okay. They are open, but they are closed in the same time. Okay. Cooperation is quite smooth if you are a member of this association. Okay. It will be extremely difficult if you are somebody from, if you are outsider. Okay. So it's like with every, close section. You need your volunteers, you need somebody who started the process, and then you can continue when you have quite strong cooperation with associations. So I'm cooperating with 3 international European associations, and always a key are good relationships. Okay. It's like everywhere. In every kind of business, it's about good relationships. Okay. It's especially in politics, I think, which and medical field is shaped by really research politics. Okay. So if you would like really to find a way to any research association, once again, you need somebody who will be interested in your project, start joint projects with associations. They are really open to cooperation with win-win situation. Okay. And then the cooperation will be already done.
One additional question, because personalized medicine is a transversal methodology. It can be applied to different disease area. So how this can, I mean, on which level can happen the cooperation? Because it's not, there isn't a medical society of personalized medicine. Personalized medicine is an approach which is applicable to different disciplines. I mean, on which basis this collaboration can be established? I mean, how to involve? I mean, what can the medical society, since you are part of it, can bring to the personalized medicine, let's call it movement?
Dissemination, the approach from the point of healthcare professionals, involvement of patients, because they are more and more interested in cooperation with patients' associations. And the voice of patients' associations is more and more important. As well, if you will need any field for pilot projects, like in different settings, they have a network of institutions which could be involved in such projects. So there's different possibilities. It's really depend on purpose.
Okay.
And what is important that the professionalists, the truth is, they show the personal medicine to citizens.
Okay. Oh, okay. This is important.
Yes.
Okay. And when you say dissemination, you also mean some of, I mean, like clinical guidelines or like bringing personalized medicine to the patients and to the healthcare professionals.
Including in guidelines, including in recommendations, because not each recommendation is really guideline.
Yeah.
Including in non-official recommendations, like discussion panels, like advisory boards.
Okay.
So it's really important impact on the really person which will be your key stakeholders for personalized medicine.
Okay.
Somebody who is really at the end of way between patient and really outcome of personalized medicine.
Okay. Clear. Wonderful. Thanks. Is there a question from the audience? Jean-Luc?
Compliment, because I think it's a very interesting thing, this use of the academic association to disseminate. And it's a problem that is for all projects. At the end, you have recommendation, and you want this recommendation to be taken. And what I don't completely understand, because I'm not very familiar with this, you said it's not easy to enter in this association. You need to have kind of a godfather. But after the dissemination is probably very efficient inside the society, but what is usually the impact outside the society? Because of course some societies are very known. The proceeding of the American Association has a strong impact, but there are many associations that are not very known. So what is the impact? And so that means that for a project in terms of strategy, does it really work to map the different association and be a little bit picky and say, or is it to have a very large and broad approach to have the largest network possible?
So usually there's like one or two associations for one specialty in medicine, like let's say you have cardiology association and you have associations which focus on internal medicine, for example, pediatry and so on. Associations are cooperating with each other, so then you have a more wider impact, and associations are covering as well not only institutional members but as well individual members, what means physicians working really with patients. So when you need implementation of personalized medicine really in daily life of patients and their caregivers, you need a person who will really believe in personalized medicine approach. And this is a member of these scientific associations.
Okay, wonderful. Go ahead, Monica.
Just again for the dimension, medical societies or these associations, I assume they are often on local or let's say national level, right? So because isn't it the language also barrier sometimes?
Not really on local levels, because you have regional departments of associations, then you have national level, then you have European level, and then you have world level.
Which are the easiest to connect with? Where do we find our bodies to connect?
It depends on purpose. It depends what you really would like achieve. To start pilot project, regional department. To have a more wider influence, I would say national and European level in the same time. Because national guidelines, let's go back to cardiology, are based on European guidelines and recommendations. So if you would like to have something included in national guidelines, you should talk with European Association. But if you need a more wider approach, you should go in the same time to European level and world level, like it's with family physicians, for example. Because WONCA Europe, which is a European level for family physicians associations, is really the voice of WONCA world, but on the European level with specific aspects of family medicine in Europe, for example.
Wonderful, thanks. Additional questions? I'm sorry we got stuck with this, but it's attracted our attention. Dorota, congratulations again for the great work and in general for the great support you have given to this network with your expertise. And since it would be a pity to lose Lower Silesia as a partner in the forthcoming EPI-PerMed, and we have Lower Silesia Marshal Office here, I would like to wish that you also join the partnership. That would be really amazing. Thanks again.
Thank you very much, and it will be our joint. Yeah. So we will see if it will become the truth.